Every single year, roughly 600,000 spinal surgeries are performed in the United States alone. Nearly half of those patients are over the age of 65. And here is the part that should make you stop and pay very close attention. There is something the data has been showing for years now. Something that most surgeons will never volunteer upfront. Something that gets buried under medical jargon and rushed consultations and the overwhelming pressure of a diagnosis. For many older adults, going under the knife does not just fail to help, it makes things measurably, documentably worse. Right now, there are 5 specific surgeries being recommended to seniors across this country on a routine basis. Procedures with risk to benefit ratios so lopsided that if most patients truly understood what the research showed, they would walk out of that consultation room and never look back. The problem is, most patients never get to see that research, not before it is too late. I have spent years reviewing these outcomes. I have gone through the studies, the trials, the follow-up data, and what I found is something every senior, every adult child, every caregiver deserves to hear before anyone picks up a pen to sign a consent form. I am Dr. Louren Hayes. This channel exists for one reason: to give seniors the clear, honest, evidence-based medical information you deserve. Not watered down, not softened, the real picture. Every week, I go through the latest research so you can walk into any medical appointment fully informed and completely prepared. If that matters to you, subscribe right now, because what is coming in the next few minutes could change a decision that cannot be undone. Let us get into it. Starting with a surgery performed over 450,000 times every year in this country alone. Number 1. Elective lumbar spinal fusion. You have been living with chronic back pain. Some days it is manageable, other days it stops you completely. And then a surgeon sits across from you and explains the plan with calm, clinical confidence. Fuse the unstable vertebrae together. Eliminate the movement causing the pain. Problem solved. It sounds logical. It sounds like progress. It sounds like relief. But here is what that surgeon may not have mentioned. A landmark study published in the New England Journal of Medicine followed patients for 4 consecutive years after this exact procedure. Researchers wanted to know, plainly and honestly, whether spinal fusion actually worked better than the alternative. The finding was unambiguous. Outcomes for spinal fusion in patients with degenerative spondylolisthesis were not significantly better than supervised physical therapy combined with targeted pain management. Not significantly better. After 4 years of data, after hundreds of patients, after everything. And that is before we even begin talking about what surgery can cost you when things go wrong. For seniors, the complications are not abstract possibilities. They are documented realities. Infections developing at the surgical site, hardware placed inside your spine, failing and requiring a second operation to correct. A condition called adjacent segment disease, where the vertebrae immediately above or below the fusion begin to break down under the extra mechanical stress. And during the long months of recovery, older adults face elevated risks of blood clots, pneumonia, and muscle loss that the body may never fully reclaim. Margaret was 71 years old when her surgeon recommended lumbar fusion. She was active, independent. She walked her dog every single morning without thinking twice about it. She trusted the recommendation. She went through with the surgery. 2 weeks later, a wound infection developed. She spent the next 6 weeks in a rehabilitation facility. A full year passed. She still had not returned to her pre-surgery activity level, and her pain was roughly the same as it had been before the operation. Her surgeon described it as an unfortunate outcome. What no one told Margaret before any of this happened was that there was another path available to her. 12 weeks of targeted physical therapy, research-supported, comparably effective, and not a single incision required. Before we move forward, I want to ask you something directly. Have you or someone in your family ever been recommended for spinal surgery? Drop a comment below and tell me what you were told. I read every single one, and your story may protect someone else from a decision they cannot take back. Number 2, radical prostatectomy for low-grade prostate cancer. For men over 70, this may be the most important information in this entire video. The PROTECT trial is one of the largest, most rigorous randomized studies ever conducted on prostate cancer treatment. Researchers tracked over 1,600 men for 15 years after diagnosis. The scale of this study is significant. 15 years of follow-up data is not something you can dismiss. The conclusion stopped many physicians cold. Men with low-risk prostate cancer who chose active surveillance, meaning careful monitoring without intervention, had essentially the same survival rates as men who underwent surgery or radiation, the same survival rates. But the men who had surgery did not come through unaffected. 30% experienced long-term urinary incontinence. 66% reported significant erectile dysfunction. These numbers deserve a moment of silence. This is not a temporary inconvenience during recovery. This is a permanent restructuring of daily life, of dignity, of intimacy, of everything that word quality of life is actually supposed to mean. For a man over 70 with a Gleason score of 6 or lower, prostate cancer in this category is biologically slow. The statistical reality is that you are far more likely to die with this cancer present in your body than to die from it. That is not a reason for complacency. It is a reason for precision. Regular PSA tests, periodic biopsies, disciplined, informed, watchful waiting. This is not giving up. This is making a sophisticated, evidence-supported decision based on what the data actually shows. Any physician who dismisses active surveillance without walking you through the PROTECT trial data is not giving you the complete picture. You are entitled to the complete picture. Number 3. Open heart surgery for aortic valve replacement when a less invasive option already exists. Aortic stenosis, the progressive narrowing of the heart's main valve. It becomes increasingly common after 65, and for decades, there was only one real way to treat it. Crack the chest open. Stop the heart. Use a bypass machine to keep the patient alive while surgeons work. Then close everything back up and hope the recovery goes smoothly. For elderly patients with multiple health conditions, that procedure carries enormous risks. Then the landscape changed entirely. TAVR, transcatheter aortic valve replacement, a new valve threaded through a catheter inserted into an artery in the leg. No chest incision, no bypass machine, no broken ribs, no weeks of immobilized recovery for a body that may not have weeks to spare. The PARTNER 3 trial and the Evolute low-risk trial both demonstrated that TAVR produced outcomes equivalent to open surgery in intermediate and high-risk patients. And in elderly patients carrying multiple health conditions, TAVR did not just match open surgery. It outperformed it. In 30-day survival, in recovery speed, in measurable outcomes that matter to real people living real lives. So if your cardiologist recommends open valve replacement without once mentioning TAVR, you need to ask one direct, non-negotiable question. Am I a candidate for the transcatheter approach? For most patients over 70 with aortic stenosis, choosing open surgery in 2024 requires a compelling, specific, well-documented justification. Not habit, not institutional preference, not a default, a justification. Now I need to pause here, because surgery number 4 is the one that surprises people the most. Almost nobody expects this one. Number 4, elective repair of asymptomatic inguinal hernias in older adults. An inguinal hernia is a bulge in the lower abdomen or groin where internal tissue pushes through a weakened point in the abdominal wall. Many seniors discover they have one through a routine exam or an incidental finding on an imaging scan ordered for something else entirely. And then a surgeon recommends fixing it. But here is the question almost no one thinks to ask. Does it need to be fixed right now? If you have no pain, no discomfort, no limitation in your daily activities, the research now strongly supports one approach over immediate surgery: watchful waiting. A study published in the Annals of Surgery followed elderly patients with asymptomatic hernias for 5 years. The overwhelming majority never progressed to emergency complications, and their reported quality of life was comparable to patients who had undergone elective repair. Meanwhile, hernia surgery in a 75-year-old with even mild heart disease or diabetes carries genuine anesthesia risks, a recovery period of 4 to 6 weeks, and a meaningful probability of developing chronic nerve pain at the surgical site that can last indefinitely. If your hernia is not affecting your life, document it. Monitor it with your physician. Watch it carefully. And unless it becomes painful, rapidly enlarging, or physically trapped, understand this clearly. There is no urgency to cut. None whatsoever. Number 5, elective colon resection for recurrent uncomplicated diverticulitis. Diverticulitis affects roughly 1/3 of all adults over the age of 60. Small pouches form along the colon wall and periodically become inflamed. The episodes are painful and disruptive, and after 2 or 3 of them, many surgeons recommend the same solution: remove the affected section of the colon entirely. For decades, this was textbook, standard practice, the accepted protocol. Then the evidence arrived and quietly dismantled it. The direct trial, published in JAMA Internal Medicine, followed patients through 5 full years of data comparing elective colon resection against conservative management for recurrent uncomplicated diverticulitis. The result was clear. No meaningful difference in quality of life. Over 5 years. For elderly patients with cardiovascular disease or diabetes, colon surgery is not a minor undertaking. Anastomotic leak, serious infection, prolonged hospital stays that destabilize everything a senior has built in terms of health, independence, and recovery capacity. One word carries everything in this conversation: uncomplicated. If your diverticulitis involved an abscess, a perforation, or a fistula, that changes the calculus entirely. Surgery may be the right answer. But if your episodes have resolved with antibiotics and rest, with no dangerous complications, the evidence no longer supports rushing to the operating room. The data says wait. Before agreeing to any elective surgery, Dr. Louren Hayes recommends asking your physician 3 specific questions. Write these down. Question 1. What does the published research show for patients my age with my specific health conditions? Not the general population, not the average patient in a trial, patients who look like me with my history, my age, my other diagnoses. Question 2. What is the full evidence for non-surgical management, physical therapy, medication, watchful waiting, lifestyle intervention? How seriously have we pursued these options and for how long? Have we genuinely exhausted every reasonable alternative before arriving at surgery? Question 3. Can I get a second opinion from a specialist at an academic medical center? A surgeon operating within a community hospital system may have different institutional pressures, different patient volumes, and different incentive structures than a specialist at a major university hospital. A second opinion is not an act of distrust. It is your right as a patient. It is the medically responsible thing to do. And any physician worth their position will respect you for asking. Keep all your imaging results and lab reports organized in a single folder. Bring a trusted family member or close friend to every surgical consultation, not because you cannot handle the information alone, but because anxiety compresses our ability to absorb details. A second set of ears catches what stress makes us miss. And above all, do not let urgency be used as a tool against you. Genuine surgical emergencies are unmistakable. They arrive with objective, undeniable clinical signs. Elective surgery, by definition, involves time. And if someone is pressing you toward the operating room faster than feels right, faster than you have had time to process, faster than you have had the chance to ask these questions, that pressure itself is a signal worth examining. Slowing down is not being difficult. It is being informed. It is being your own advocate. And in medicine, that distinction can change everything. Please consult your own physician before making any changes to your personal care plan. Everything presented here is drawn from published medical research and is intended for educational purposes only. It is not a substitute for individualized medical advice from a qualified healthcare provider who knows your full history. If this video made you pause before signing a surgical consent form, leave a comment right now. Type reviewing my options if you are committing to asking these questions before any future procedure. Type sharing if you are sending this to a parent, a spouse, a sibling, or a friend who needs to hear it before they make a decision they cannot reverse. Or simply tell me which surgery on this list surprised you the most. I want to know. Your comments do more than you realize. They help this channel reach seniors who are facing these exact decisions right now, tonight, this week, before an appointment they are nervous about and unsure how to navigate. If you are not yet subscribed, do it now. Every week, Dr. Louren Hayes brings you research-backed health information built specifically for people over 60, because you deserve the same quality of evidence your physician has access to, presented honestly and without agenda. Next week, we are covering 5 prescription medications that geriatric specialists now flag as particularly risky for seniors over 70, including one blood pressure drug that nearly every primary care physician still prescribes as a matter of routine. You will not want to miss it. This is Dr. Louren Hayes. Ask the hard questions, take the time you need, and never forget that advocating for yourself is not a disruption. It is exactly what informed patients do.